Okay, and we're live. All right, folks. Cheers. I earned this one tonight. Oh, yeah. Lots of algebra 2 tonight with the kiddos. Good times. All right. Let's get this evening started. I'm going to give you guys a couple of minutes to jump on board. All right. As you jump on board, let me know who you are, where you're from, and what's in your coffee mug, especially if you're a cool kid and you got one of the Cosi Talks mugs or glasses. Let me know about that. See some folks popping on board. Folks, if you're watching the replay, please put replay into the comments section. I do like to go back and see who's watching the replay and if there's any questions that I can pick up and answer in the meantime. So if you're watching the replay, hit replay for me. Thanks. All right, guys, I see some folks popping on board. Give me a shout out. Hey, Harsh, how are you? Oh, I always love seeing you on board here. Hey, Keith, man, it's been a while. Cheers, man. We got the whole Virginia crew on board this evening. Hey, TC from South Florida, Coconut Creek. There's my other Floridian there, man. All right, we got Doug Campbell on board from Canada. I got my Canucks on board tonight with herbal tea. We got David Donahue, green tea in South Carolina. We've got them from all across the board tonight. Hey, Brett, you drinking your iced tea? Where's your iced tea, Brett? All right, guys, I am enjoying my decaf. I treated myself to my favorite brand of decaf that we have out here in Fresh Market. It's been a long day of work and kiddos, and I am happy to be here at this part of my day. Getting ready to answer some of these questions. Hey, Johnny V from Poughkeepsie, New York, in the Cosi Talks house. Man, Johnny, it's good to see you. All right, guys, we're going to give you Mountain Dew tonight, Brett. All right, we got Susan on board. Van Gregory, it's October 6th. So, yes, you are watching the live show, Van Gregory. Thanks for coming. Susan, always nice to see you as well. All right, guys, I am broadcasting as well to my YouTube channel. So, for those of you who have been kind of sharing about the show with folks and some folks who are not big fans of Facebook and whoops, the hiccup they had a couple of days ago, you can also find me on my YouTube channel where I'm streaming live there as well. TC is let's see. TC says, I'm a BK and I'm now short 2 fingers. All right. Well, TC, you're in the right place, man. Chuck, it's good to see you. My pleasure. And Chuck, I love that you're watching me from my YouTube channel. Thank you, sir. All right. We got Tom McIntyre on board. We got my other PT in the house, Patrick, there to keep me in check. We got Karen. It's happy birthday, guys. Say happy birthday to Karen. It's Karen's birthday and she's joining us this evening. So say happy birthday to Karen. Hey, compadre, I am so glad you're here, man. Monday, hopefully get your check socket. Well, that's a really nice belated birthday present for you, Karen. That's awesome. We got Cindy Norris on board with her kiwi strawberry water. How very fancy of you, Cindy. We've got Trent. Welcome on board. We got Andrea. There's my other OT. So there's my OT and my PT there to keep me in line and make sure I behave. All right. Everybody's saying happy birthday to Karen. Thank you, guys. Oh, well, thank you for sharing your birthday with us, Karen. That's real sweet. All right, guys, we're getting some people on board here. Hey, what's up, Mark S? What's going on? All right, guys, we're going to go ahead and get started. For those of you who are joining me for the first time this evening, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now. It's going on close to 19 years, guys, closing in on my 19-year anniversary. I have a private clinic here, Palanca, which is exclusively for working with the limb loss community. And guys, October is a big month for me. We've got Hispanic Heritage. We've got Breast Cancer Awareness Month, and we've got Physical Therapy Month. It's like 3 whammies, 3 check marks for me. So October is my month. All right, guys. And in a couple of weeks, I'm going to have a really special guest on board. She's going to be coming on board. Her name is Jamie Goldman. She is the founder of Warriors for Hope, and her tagline is no legs, no breasts, no problem. So she is a dynamic woman, and I cannot wait for her to tell her story here on the show. She is an amputee. She is a breast cancer survivor. So a lot of beautiful, beautiful things that she has to share coming up in a couple of weeks. And the other thing, I've got to plug this, guys, and I want you to stay with me on this one. November 3rd, right? Those of you who know what's going on November 3rd, put it in the comments section. November 3rd, those of you who have not signed up for my email subscription, you need to sign up so that when a time comes, you are going to be the first one to find out what's happening on November 3rd. So November 3rd, on my Wednesday show, I will be announcing that super secret top project I've been working on for the past 2 years. It's going to be the big launch. And those of you who are on my email subscription list, you're going to get the news a little bit earlier. And there might even be a little discount in there for you. Just saying. Yes, big news. Brett knows. Mark knows. Mark. Shh. Barbara knows. We've got Andrea knows. That's right. The big reveal. Harsh to reveal secret. Yes, there we go, guys. All right. So get it in your calendars. Sign up for my email subscription if you haven't already done so. I promise I don't spam the inbox. I only send one email a week with the links to the show and everything else. So I didn't have too many questions this week come in. So feel free to go ahead and put those questions in the comments section. So I'm going to get started with the ones that did come in. All right, so I kind of went haunting around the support groups this week just to kind of see, okay, what's the chitter chatter about? And I really like this question because this is a question that I address a lot with my patients, especially when they're reaching the tail end of their program with me. So this individual says, I need to get a new phone mount for my car, and I'm kind of afraid of bottoming out at the back of Walmart, wearing this thing, the prosthesis, 7 to 10 hours a day, but I have this irrational fear of slipping down too far in a store. Should I just go for it and take an extra sock in my pocket? Okay, so when he's referring to bottoming out, guys, he's referring to his residual limb hitting the bottom of his prosthesis, which we don't want. I still have my socket here from the last show. Okay, so when you're wearing your prosthesis, okay, the bottom of your residual limb should not be hitting all the way down there at the bottom. You should not be feeling the bottom of your socket. It should just barely be grazing it just at the bottom, right? There shouldn't be any pressure at the bottom of the socket. This is not where the weight of your body goes, okay? The weight is carried through your soft tissues, and also if you're an above the knee amputee, through the ischialtuberosity in some cases, okay? Not the bottom, okay? So how do you resolve bottoming out, okay? Usually it means that your limb has shrunk, right? And you need to add a sock or two, okay? And that's where the science and the art meet at that point, okay? For those of you who are newer amputees, this is probably one of the more frustrating aspects of learning how to use your socket, is knowing when to add a sock, when to take a sock away, okay? And I'm kind of excited about seeing all this new technology coming out with adjustable sockets because it's making that part just a little bit easier. So hopefully we'll have a little bit more of that in the coming year, coming up right next. Okay, so what are you supposed to do? I always tell my patients carry socks, right? For the men, they usually have some sort of bag or some fanny pack or something that they keep, or they can just slip a sock or two into their pockets. And for the ladies, it fits right into your purses and pocketbooks, okay? And yes, there may be a time when you are out in public and you're bottoming out and you got to put a sock on, okay? And a lot of times my patients are just like, but that's like really personal just to take my leg off in public and put a sock on. And you're right, it is. And for some people, they have no problems. They I had a patient tell me, he goes, yep, I just dropped trowel in the middle of the store and put a sock on and went on my way. I said, okay. So some patients are very comfortable just removing their socket, adding a sock, and going about their business. Other folks do like a little bit more privacy. So what I tell folks is when they're first starting to go out in public, right, in Walmart and church, those are the two places my patients like to go. So that's what we try to help them out with. If you know that you're going to a specific Walmart, think about where the bathroom is, right? Think about where the benches are in that Walmart so that if you have to sit down and take off your socket to add a sock, you can kind of do so a little discreetly, right? The second thing is the fear that this gentleman was referring to was obviously if he's bottoming out, is that socket getting too loose? Is it going to fall off? Is he going to have a fall? So when I have a patient who's kind of a little nervous about this type of thing, I'll tell them, grab a shopping cart, right? I tell them their homework assignment is to get from their car to the entrance of the store walking on their own. And that's something that we've been working with them on physical therapy. And I usually tell my patients, I want you to practice walking across that parking lot, right, on your own. Okay. And then you just got to make it to the entrance of that store, because at the entrance of that store, you got those lovely shopping carts that my kids love to whiz around on. Right. So if you notice that, okay, I'm bottoming out on the socket, at least you have that little bit of a shopping cart to give you a support to get you to where you need to go. Okay. And the third thing is especially in the first few times that you're heading out and you're getting yourself back into the community, take a buddy. Take a buddy. Take a loved one, a family member, friend, a caregiver, somebody that you're comfortable with, that they know if you're having a problem, so they'll be able to kind of spot you and help you find a chair or bring a chair to you, or maybe even stand in front of you while you're changing your sock out. Okay? All right, guys, let's see what these, I see comments whizzing in. I'm like, I want to hear about what y'all are saying. Mark, you think you can blackmail me, but son, I wouldn't try it. Hey, comadre, glad you could make it. We got Susan on board, and she says, I never really had any phantom pain, but lately it's been happening a lot, and nothing has changed for as far as weight. What could be causing this? Susan, we're going to get back to that in just a minute. Hey, Bonnie, glad you could join us. Hey, Kim. We got Liz on board. Oh, Liz. Mohamed, I'm so glad you're here. We've got, and Molly. Oh, I've got a full complement of a lot of my colleagues on board. I'm loving this. Johnny says, try putting a sock on it when you're on the slope skiing. That is something I have yet to see someone do, Johnny. I would love to see a video of you doing that. Patrick, excellent point. Simulate it at home. Do a practice run at home, right? Hey, Alex from North Carolina, do the best you can. Yeah. So guys, that's kind of it. Any hacks from you guys? I want to hear from you guys. Those of you, especially who are more experienced amputees, think back to the time when you were first learning to use your prosthesis and you were first venturing out, whether it was to the grocery store, to go to church, to go to a friend's home, an unknown new environment, okay? What was the trouble you ran into and how did you solve it? Was it fear of not knowing how your leg was going to react? Was it that your leg keeps spinning on you, or what was it that caused that obstacle for you when you were first learning to get back out into the community? All right, let me catch back some of these questions. So Susan's having phantom pain lately that she never used to have, and nothing has changed as far as weight. What could be causing this? Susan, a few triggers of phantom pain: stress. Okay, that's a big one for my patients, and honestly, it's probably one that's most overlooked. Mainly because folks, we're so used to living in a high pressure cooker environment, especially now with COVID and everything and all the fluctuations happening in our society and everything crazy going on with the TV. And yeah, so stress is a big one, Susan. And if your stress level has been kind of creeping up on you slowly, it could start kind of manifesting itself with some phantom pain. Other physical causes, Susan, neuromas. That's another one. If there's a neuroma that could be possibly forming, and that could be kicking off some phantom pain. The fit of your socket. Okay, so you said you haven't had a change in weight, but perhaps you're still having some changes in your limb volume. Again, I'm just kind of throwing stuff out there. There could be something in your socket that's irritating, and it's an irritant, and maybe possibly triggering that phantom pain. Okay, so just a couple of things that you can kind of just troubleshoot through. Susan, on my YouTube channel, and let me just put that up there for you, I did a show with the fabulous Greg Menino, and we did an entire show on phantom pain, residual limb pain, phantom limb sensation. So I would encourage you to go and watch that show and just see. We go through all of the triggers and also how to start working on it from your home, okay? All right, let's see. Okay, Karen says, I've noticed the bottom of my above the knee stub gets so achy, deep in the bone, but just at the tip. I worry about walking when I finally get my leg. So Karen, I'm assuming that you're just kind of fresh out of your surgery, right? So it takes time, right? Some of these residual aches and pains can last for a few months, and it'll go up and it'll go down. When you have especially if you're very active, okay? If you're very active, then your body's going to have a little bit of an inflammation response, and then it's going to get better. And then it's going to get a little bit of an inflammation response, and then it's going to get better. The thing to note, Karen, is when you do go in for that check socket, you need to communicate to your prosthetist if you're hitting the bottom of that socket. Okay, so remember what I said? Where'd that thing go? Here it is. Okay, so Karen is an above the knee, right? You should not be feeling any pressure on the bottom of your residual limb when your limb is in the socket and when you're in standing. Okay, you should not be feeling any pressure there, and that's something that you need to communicate with your prosthetist. And chances are, if you're a little bit sensitive on that end, it won't take much for you to feel that you have pressure in that area. Okay. Pre-plan. Yes, Patrick. And that's a huge one. Going back to our Walmart question, I tell my patients when I do the same when I worked in the home health sector, and I would help my patients transition into getting back into the community, especially with church. Church is a big one in my area. Helping my patients plan, where is the parking lot? Do you have access to the handicap parking spot? If so, where is the nearest entrance from that parking spot? Do you have to go over any curbs? Do you have to go on any ramps? Okay. Is there somebody in the church who can save you a spot in the pew that's close to the door so you don't have to walk very far? So usually with a lot of careful planning, it takes a little bit of that fear and that anxiety out of those first outings, right? And then it's just practice, 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 right? Okay, so Brett says, any tips for while I am waiting for my new socket? I'm at 15 ply, and even though I'm not bottoming out, I don't fit right at the end of my residual limb, and it causes pain and pinching after about an hour. Brett, honestly, once you get to, 15 ply is a lot, bud. So yeah, you need that new socket. Hopefully your prosthetist is going to be, kind of quick on the ball about getting you that new socket. The big thing, Brett, is be careful. Okay. Watch your skin, make sure you're not developing any kind of redness or any irritation on the skin. Make sure that you're stable. A lot of patients, when they get to that many ply, they start to lose stability in the socket because they're not as connected, right? They got all that padding there. So just take extra care when you're taking your steps so that you don't have a loss of balance and fall. And you gotta keep working with it, kind of duct tape it together, kind of keep it together until you get that new socket. But definitely, squeak the wheel with your prosthetist. Yeah. Cause if for me, guys, there's some folks who are in 15 ply and they're fine. But when folks like Brett say they're in 15 ply, it doesn't fit right. There's pain and pinching after about an hour, and that's time to get that new socket done. Okay. Cindy says, my phantom pain has been out of control. And guys, watch the videos. There's in my YouTube channel that I just put up there, I have a section called 2-minute chats. And let me just take a moment to tell you about that, because I think some of you will find that to be a helpful resource. Number one, if you can go follow my YouTube channel, much appreciated. In the YouTube channel, 2-minute chats. And basically it's 2 minutes on different topics related to limb loss. Okay. So that way, if you're not sure what it is that you want to listen to, you can just listen to these quick 2-minute videos that I did. And the one that I did was I did one on phantom limb pain, phantom sensation, and residual limb pain, right? Underneath that 2-minute chat video, I post links to other videos and resources. So if there's a particular topic you want to learn more about, look under the 2-minute chat video and you'll find more links and resources there. Okay. So that one's a big one. I try to put a lot of stuff into the phantom pain because I know that's something that concerns many of you. Ooh, that's a great question, Andrea. How much heart function do you need for safe and effective prosthetic use? Old amputee above the knee and below the knee now has heart trouble. You need so much more energy to walk with prosthetics, might need to have a tough conversation. That is a phenomenal question, Andrea. And that's really digging through my old cardiology days of working in CCU. So the first thing that comes to mind is, what is this patient's ejection fraction looking like, right? So ejection fraction is concerning about the blood that's pumping out of your heart. Normal is around 55%, right? So, we used to work with patients in the CCU, and Andrea, I'm sure you have as well, that have ejection fractions that are like 5 or 10%. These people are on the heart transplant waiting list. So obviously when you have someone who's having cardiac issues, right, you have to be careful with their energy exertion. And those of you, there's probably some of you out there right now that you probably are taking some sort of medication for your heart. Some of you who might have some sort of arrhythmia, something affecting the way your heart pumps, right? Who knows, maybe there's a heart transplant out there. I would say you need to go and monitor him, Andrea, very closely for his perceived rate of exertion. Get the parameters from the cardiologist. Whenever I had a patient that I'm just like, I would go to the cardiologist and I would have the cardiologist give me hard and fast parameters, meaning what is the max heart rate I can have my patient at? What are the blood pressure parameters? and obviously with respiratory rate. Okay, so Andrea, the good news is that this individual's already an experienced amputee. It means they know how to move and they know the mobility aspect. Okay, so once you put that aside, you treat them as you would any cardiac patient. Sorry, I lost my train of thought there for a moment. Okay, monitoring their heart rate, teaching them how to monitor their heart rate and their perceived rate of exertion. I love using the dyspnea index. To me, that's just a really easy way to teach a patient how to determine if they're way too winded or if they can keep moving. But definitely, taking it very slowly and just seeing where he can progress to. And it never fails to amaze me, Andrea. As we all know, the heart is cardiac muscle. It's muscle. So yes, if there's damage to the cardiac muscle, you have to treat it very carefully and move slowly. The same way that if you had an injured biceps muscle, you have to progress very, very slowly so that you don't injure more of that cardiac tissue. But that's where I would start, Andrea. I would say ask the cardiologist for strict parameters, what you can and cannot do, and then monitor him and just see how his body reacts. Hopefully, and here's another side of it, Andrea. If he's been an amputee for a very long time, his heart has gotten accustomed to that workload. Yeah, fingers crossed. Let's see, Karen asks, how long does it take most people to walk unassisted on a new above-the-knee amputee? Karen, that is the million-dollar question, okay? Million-dollar question. Here is the textbook answer, okay? Many of my patients will come to my clinic, and because I don't accept insurance, it's an out-of-network practice, one of the first questions my patients will ask me is, how many visits do I need in order to be able to walk, okay? For an above-the-knee amputee, ballpark figure is from 12 to 20 physical therapy visits, right? So if you're doing 2 visits a week, right, 12 will give you 6 weeks, 6 to 10 weeks of physical therapy. Now, that means 6 to 12 weeks if there's no other problems, okay? And as we all know, those of you who are experienced amputees, there's always going to be little blips along the way. So Karen, what you can expect is as you begin to do your physical therapy and learn how to use your device, your leg is going to start changing, right? Your leg is going to start shrinking down, okay? And hopefully you'll be able to manage that with socks and keep progressing with therapy. There are some cases where a person dramatically shrinks down, right? And they have to get adjustments made to the socket, or in the process of shrinking down, it changes the alignment. So they have to go back to the prosthetist and get things tweaked, right? So for me, that's where it's important to have really good communication between the physical therapist and the prosthetist, so that if there are any issues that the prosthetist needs to take care of, it can be done quickly and hopefully seamlessly without a person interrupting their physical therapy. But sometimes, Karen, that happens, okay? So it can be a setback. I've seen some above the knee amputees in as little as 4 to 6 weeks, and they're done. And then there's some amputees that take longer because they have other issues that crop up. What I tell folks, and Karen, I want you to put this in the back of your mind. Look at your progress week to week, month to month. Okay, if you look at your progress day to day, you're going to get frustrated because you're not going to see much progress. So I tell my patients, especially my patients who are starting to have problems with their socket, and we're kind of slowing down with the progress of their physical therapy because we're trying to get that socket taken care of, and they get a little frustrated. And I say, okay, just stop for a minute and think about where you were 3 weeks ago. Think about where you were 2 months ago. Okay. You've made a lot of progress, and you're going to continue to make progress. It's just going to be just a little bit slower while you get all these issues ironed out. Okay. And guys, I put the onus also on my patients and on my viewers to say, from your end, especially those of you who are fortunate enough to have a prosthetist and a physical therapist working together for your case, communication and continuing to follow what they tell you to do. Okay. The physical therapist is probably going to be giving you some form of exercise program to do at home, some sort of wearing schedule, some sort of, I call it giving my patients homework. Okay. Do your homework. Okay. Be consistent with it. the progress that you make is directly correlated with the effort and the work that you put into it. Yes? Team approach, right? Hey, Benny. Hey, man, thank you for sending me those songs. I love listening to those songs. Hey, Rhonda, we got Steven on board. Roll Tide. Hey, Damar. Keith said he felt anxiety, like everyone was staring at him when he was first heading out into the community. Mark with his boo phantom pain, it's just ghosts. Yeah. So Susan says, I've been having extreme stress in the past 3 weeks. So Susan, that would be my culprit if I had to pinpoint on something. Alex says, learning to walk over obstacles and uneven surfaces. Yeah. And that's a big one that many of my patients are like, because you've got a curb here, a ramp there, even the parking lot, right? The parking lot is like, you never realized how bumpy a parking lot was until you tried walking across one in a prosthesis, right? So a lot of times I'll take my patients out of my clinic and I'll take them into the parking lot in front of my clinic. I have a grassy area in the back, so I'll have them walk through grass, go up and down curbs, and just practice these skills. Okay. Oh, Mark says he's afraid to walk in the ocean, which hopefully, Mark, you're not afraid to do that anymore, Mr. Scuba Diver. Let's see. Johnny said, I just got back from my local ski club meeting and need to start working on my winter sports calendar juggling act. Yeah, you are a busy man, Johnny. Susan says, in the beginning, I was super excited to go out and I had no anxieties when I first ventured out. There you go. Let's see. Patrick says, does the weight go through the ischialtuberosity? Yes, it's supposed to. And actually, Patrick, we did a big show 2 weeks ago, and I talked a lot about ischialtuberosity, weight bearing in these sockets, right? So your ischialtuberosity, come here, Bob, it's your turn. Ischialtuberosity, guys, as a reminder for those of you who didn't watch that show 2 weeks ago, is your butt bone. And you got two of them. So when you're sitting down on the chair, the two butt bones that meet the chair, that's your ischialtuberosity. Okay. And our sockets have undergone a lot of evolution in the past 4 or 5 decades. And one of the big evolutions was that the way the socket is designed, right? I don't know if you guys can see that, right? The ischialtuberosity, that butt bone, tends to be in the socket and kind of resting on its own little ledge sometimes, depending on the socket. Some of the sockets have a pretty sharp ledge. Some of the sockets have a kind of more rounded ledge that the ischialtuberosity kind of rests on, okay? And at first that can be really uncomfortable because it feels like you've got something just kind of like someone with the heel of their hand right up on your bottom. So it does take some getting used to. But that is where a lot of the weight of the body will go into that area and also in the surrounding tissues around, especially, with your thigh, you've got a lot of nice soft tissues there to help pick up the slack. All right. And I will go into details now because we did a lot of that in the previous show, but some folks, they choose to have those trim lines brought down because it's not comfortable for them to have their ischialtuberosity truly contained in that socket. And some people get used to it, which means it gives them a little bit of a better stability in doing that. All right. So Cindy asks, what kind of a doctor do you go to see if you have a neuroma? So a couple of different doctors. Usually you need to go to the doctor, and I know this sounds like master of the obvious. You need to go to the doctor that knows how to diagnose a neuroma. Okay. And I say that because there's some doctors out there, some surgeons and things like that they'll see their patients. They're like, no, you're fine. And they won't screen for that neuroma. Okay. So you want to go, typically your doctors who work with amputee patients, they know how to diagnose these neuromas. Pain management doctors, physical medicine and rehabilitation doctors, PM&R doctors, orthopedic doctors, orthopedic surgeons. Your general physician probably won't know how to identify or screen for a neuroma. Your physical therapist, right? And your occupational therapist who has experience working with amputees. We know how to screen for neuromas, right? And then usually for me, if I suspect that my patient has a neuroma, then I'll send them off to the doctor to get either an ultrasound, maybe MRI. I'll let the doctor make that decision as to see if there is in fact one there. Let's see. Tom says, my biggest fear was that I would walk too far and not be able to get back to my truck safely. Yes. I always overdid it. And there was a couple of times I almost didn't make it back. And I also paid for it too. Oh, Tom. Yeah. Yeah, Tom. And that's something that when I have certain patients that that little red flag is going off and I'm like, this patient is so going to overdo it. I need to put some strict parameters on this patient. And usually what I do is I send them out with a loved one, because guys, there's those of us who don't like to take any risks and we play it super, super, super safe, almost too safe. And then there's the other end of the spectrum, those of us who like to go hot dogging, and I'm one of those people, and overdo it and end up getting ourselves in trouble that way. So if you're one of those hot dogging folks, usually I would tell them, take your wife, take your husband, take your friend, take somebody with you, okay? So that if you do overdo it, that person can quickly grab a chair from somewhere and bring it to you. Or maybe that person can be the one to kind of nudge you and say, hey, it's time to turn around and go back. Okay, because it only takes one or two times when you overdo it and you're stuck in the middle of a store realizing that you are losing your strength and energy and you don't have the energy to walk back. It only takes a couple times, right, Tom? All right. So Cindy says, I had to go to the heart doctor, high heart rate and Afib. Mm-hmm. Let's see. My pleasure, Andrea. Keep me posted. Yes, Patrick, thank you for elaborating on that. So with the Afib, you do lose. Lower ejection fraction can be an issue. You need to have your gait as normalized as possible to be more efficient, okay? So basically, Patrick is saying what we've all talked about, right? The more efficient your gait pattern, right, the less energy you're putting out to walk. So those of you who are cardiac patients and amputees, you really need to want to hone in on your balance skills, on your coordination, whatever strength that you need to work on to make sure that your gait is nice and efficient, okay? But again, those of you who are cardiac patients, you really need to talk to your doctor about what are the limits of your heart rate, okay? And if you're working with a physical therapist, they can teach you how to monitor your heart rate, okay? And how to determine if you are overexerting yourself, right? Hey, Brian, better late than never, man. Glad to have you on board. All right, let's see. Hey, we got Bobby on board and Linda. Okay, so Karen says, I was born as a BK without my foot and ankle, so I'm hoping that experience will be helpful in this new chapter. Karen, it will, in the sense that you were born with you developed a different sense of proprioception than those who were born with two anatomical legs. So Karen, you will have a little bit of a head start in that regard, okay? For you, it's gonna be learning, obviously, how to operate that prosthetic knee. And strengthening, keeping your glutes even stronger now than they used to have to be before, okay? Yes, rehab progress is rarely linear, and ups and downs look at overall gains through time, and that's exactly it. This is one of my patients in physical therapy. That over the course of time, we see hopefully a trend up. Okay. The other thing, guys, especially those of you who have medical conditions, if you have diabetes, blood pressure issues, issues with autoimmune disease, kidney issues, right? Those of you who might be on dialysis, okay? These are all situations that fluctuate and can fluctuate on a weekly and sometimes even daily basis. And that can throw monkey wrenches into the situation, okay? So when I have a complicated patient come in who has one or more of these issues, I'm really on top of them about making sure that they're watching their glucose, making sure that they're watching their blood pressure, making sure that they're watching whatever dietary restrictions or plans that they need to be on to keep all of this in check. Okay, because that to me is always what gets me as a PT, is when something goes wrong with their medical condition, we can't continue to do the physical therapy and make the progress we're making. Okay, but guys, there's gonna be several times you fall off that horse, and if you fall down 77 times, you get up 78. Mark says, I like jumping in the water from the boat. I need some coffee. Oh, I love it, Alex. Alex says, a solid relationship with both prosthetist and therapist is critical. Do your Excel, use homework every night, and PT never quit. Amen to that. Hey, Tisha, glad you could join us. Johnny says his orthopedic surgeon was the one who diagnosed the neuroma. Yep. And Susan says, how do you screen for a neuroma? With these guys, hear me out. So usually if my patient will come in and they'll say, oh my gosh, I have this pain, or my phantom pain is really through the roof. And usually with my neuroma patients, they'll say it hurts here, and they can point to a pretty specific place on their residual limb. And at that point, I get my really high technology diagnostic tools, my 2 thumbs, and I'll go kind of fishing for that neuroma. And I know that sounds really cruel. And actually somebody was giving me a hard time the other day. They're like, are you really that mean to your patients? And I'm like, yes, I am. But basically I'll take my thumb and I'll kind of push gently in the area that they are experiencing the pain, right? And I'm pushing to see, okay, is there any scar tissue that I can palpate here to see if the scar tissue is adhering to something causing the pain? Is there any like bony formation that I'm feeling in there? Is there like a bony spur that I can feel? Sometimes you can't feel them, but sometimes you can feel them because they're pretty big. And other times I'll just push in and the person says, boom, seeing stars, that's my pain. And that's usually my indication, like, yeah, you might have a neuroma because it's pretty pinpoint tender, okay? And at that point, I will usually tell them, make an appointment with your doctor, right? Let's get this thing screened. Let's put some eyes on it, and make an appointment with your prosthetist. Because the first thing I want is the prosthetist to see if the prosthetist can make any adjustments to the socket to alleviate the pressure in that area. That's usually my first choice of treatment there, okay, to see if that can happen. All right. Mark says I'm a mental patient. Mark, I'm just not going to go there with you. I'm not going to. Hey, Michelle, glad you could join us this evening. Let's see. Oh, Brett too. All righty. Okay, so Susan says, I'm going to my amputee specialist at the hospital tomorrow to check for a neuroma to see why I cannot walk very far without pain. And guys, I joke around about using my thumbs as diagnostic tools, but sometimes that neuroma is pretty deep in there and I can't even get to it with my thumb. But again, once I start to suspect a person has a neuroma, I take them out to the doctor and have them get that screened just so that they can start putting together a plan of care. Love it. You can tell Patrick's a home health therapist, man. He's got all the home health tricks. He says, I'm home health care PT, and I advise make sure you can make it back home. Add a house as a progression and have safety nets, family walking with you, plenty of chairs around for safety, and driveway and stair landing set up for success. Yes. I miss working home health. It was fun working home health. I got to really know my patients, and I enjoyed that part. I really enjoyed it. Oh, Linda, thank you. All right, let's see. Thank you, Patrick. Ouch, Mark. Well, that would hurt. Oh. So Susan thinks, I think I might have a neuroma in the back of my residual limb. I can pinpoint the area of pain, and it also hurts when it touches the couch or bed when my leg is off. And again, Susan, there's a couple of things that can cause that. It could be scar tissue. It could be the neuroma, which is scar tissue formed around the end of that nerve ending. It could be maybe a little bit of a bone spur. It could be an irritation. There might be a tendon in there, a residual tendon that's irritated. Again, at that point, you're doing the right thing by going back to your doctor. Oh, Leanne, thank you so much. Oh, wonderful. So Leanne says, big shout out to you, Cosi, and your guests like Reggie. I'm going back and watching your past shows to see what types of foot symptoms I would like to try next. I just got the go-ahead for a new set of arms, hook, and new legs and feet. You are going to get a whole makeover, Leanne. So go get your hook on, Cosi, and show the uppers their hook options. I know, Leanne, I need to do an upper extremity show. I do. And all I can say is I'm really trying to get that in the works. That's all I'm going to say. I am trying to get that in the works. But yes, Leanne, thank you for that shout out. And yes, guys, there's probably one of my favorite all-time shows is the show I did with Reggie Showers. It was actually one of my first show where I had a guest on board. He was my special guest. We broadcast out of my garage. We got 45,000 views on that show. You can still find it in my archive section in my Facebook archives. It's from like 2019, February 2019. But it was a fantastic show because we covered all the different classifications of prosthetic feet. All the differences between what to consider in terms of your mobility for what kind of a classification foot, who qualifies for that kind of foot. I mean, it was a good show. It was a good show. And it's one of my foundation shows that I love referring people to, especially when they're in the market for a new foot and they don't know where to start. So I'm just going to give you a quick ditty on that, guys. You've got so many different classifications of prosthetic feet, right? You've got your Satch foot, you've got your single axial, multi-axial, energy storing and response, or sometimes called the dynamic response. Now we have hydraulic feet and we have hydraulic microprocessor feet. Okay. And then on top of that, all these wonderful companies put 40 million different names on their products. So it's really challenging sometimes to figure out where to start. Okay. So I tell people, put all of those names and companies aside for a moment. Okay. Learn your different classifications, right? Understand what is a single axial, what is a multi-axial, what is a dynamic response and hydraulic foot, right? Learn those basic classifications. Nowadays, a lot of the feet, they're mixing in little bits and pieces from those classifications to make, and I call it a hybrid foot because it just has a little bit of this, a little bit of that. Okay. So let's say you've determined that you are a great candidate for a hydraulic foot ankle system. Okay. Then I tell you, go back to those big companies, you know, some of the big ones, Oser, Ottobock, Blatchford, College Park, Freedom Innovations, Proteer. Look at those companies and see who has the hydraulic foot. And that kind of helps narrow the field down. Okay. So that's kind of like my general way of approaching how to look for a new foot. So thank you for that feed in, Leanne. Went off on a tangent on that one. Okay. A ver. Cindy asks, is getting of a neuroma a big operation? It is a surgery, Cindy. There's two ways to go about it. And we've done lots and lots and lots of shows on this one, Cindy. And I would encourage you, Cindy, go to my YouTube. I know I'm plugging my YouTube channel, but that's kind of where I'm putting all of my stuff. So it's one place that you guys can go to find this information. Cindy, if you go to my YouTube channel, there's a video I did in July, one of my live shows. And you'll see it because there's a gentleman sitting next to me in the video, Dr. Leonard Dedesi. He's an orthopedic surgeon and he works on neuromas. Like that's part of what he operates. So there's two ways about it, Cindy. You can either have the neuroma resected, where basically they just carve it out, right? But then there's always the potential for it to grow back again, okay? So what I encourage people is if they have a diagnosed neuroma and they know they've gone through the conservative options and the only thing that they have left on their plate is surgery, TMR, RPNI surgeries. Okay, these are specialized procedures that not only take out the neuroma, but they take that nerve ending and they plug it back into muscle tissue. Okay, that's kind of just a really quick and dirty explanation of it, Cindy. So it is a surgery, yes, and that's why I say it's the last resort. You know, if there's a conservative way for you to treat that neuroma, either by getting the socket adjusted in some way, a specialized liner that might help take the pressure off the socket, injections. You know, there's lots of things that you do before you work your way up to surgery, because obviously surgery is surgery, right? You're out for about 4 to 6 weeks, depending on the severity of the neuroma. I will say this though, Cindy, the people that I've seen whose neuromas were absolutely devastating to their quality of life, like they couldn't walk, they couldn't get through their daily lives, the surgery was a game changer for them. Okay, so that's where I tell folks, if this is something that you're experiencing, have these conversations with your physicians, have these conversations, find the surgeon, right? Find the surgeon that knows these procedures and can talk to you about them. Liz, I know, girl, we got to make it happen. We got to make it happen, Liz. Okay, I know Linda says uppers. I know. Anything about knees? Yes, Linda, I've done not as many shows. I need to do more shows on knees too. I need to do shows on uppers, adjustable sockets, and knees. Y'all are giving me my to-do list for 2022. All right. So for the knees, yes, I have done shows explaining the different classifications of mechanical knees and also the different classifications of microprocessor knees. And I believe it's a show I did with Blatchford on the links, and that's their microprocessor knee and their microprocessor ankle. Integrated limb system. It's all connected together. So Linda, you'd have to scroll through a little bit. but if you go through my video archives, you will find it and it's labeled. Michelle asks, is it possible that it's a neuroma, a softball or not the size of a quarter, that is on the outside of my residual? Michelle, if you mean by outside, do you mean like on the back or like outside your skin? Can you just clarify that for me a little bit? Molly says, trial feet in your activity level. Great option. Yes, it is. And I got to tell you, I love the companies out there that have trial programs, not only for their feet, but also for the knees. I was at a prosthetist clinic this week, and I was doing a K-level functional testing for a particular patient. And in walks the sales rep from a really great company that makes really great microprocessor knees that will remain nameless, right? And this particular sales rep said, yes, we can certainly work something out so a person can trial a microprocessor knee to see, you have to put some paperwork together and you got to make it work, but it's possible. It's possible. Okay. So when it comes to feet, especially, yes, there are so many companies out there now that have trials, free trials available with their feet, guys. And that's something that I hugely advocate for. I mean, how many of you take your cars on test drives before you make that final decision on driving away with that car? So why wouldn't you do the same thing with the foot that you wear every day? Okay. And again, squeak the wheel with your prosthetist, right? Ask to trial at least 2 feet, guys, at least 2 feet. Even if you have your heart set on 1 foot, trial another one from a different company just so you can see the difference. Huge fan of that. Yes. Keith says, I was squeezing a tiny blister under my stump and the pain kept increasing when I kept messing with it. Yeah. I suspect it was a nerve ending close to it because every time I poked it, I had phantom pain at the same spot on my phantom toe each time. Hilarious. Dude, Keith, you're killing me here. If you have a blister, leave it alone. Leave it alone. Let it heal. Especially if you're poking yourself with a nerve poker that way. You're killing me, Keith. All right, guys. Sorry, I'm like trying to scroll through here. Oh, Jason Kroger. He's one I would love to connect with, Leanne. That's awesome. Steven got casted on Friday. Oh, yeah. Okay, sorry. I'm like trying to get through these questions. Ooh, that's a good question, Theresa. Theresa asks, I am going to attempt to do a 5K walk on October 17th. Yay. Training for it now. Would you advise me to wear a liner to prevent blister formation? I'm getting a smaller liner and had a socket adjustment today. I will ask my leg gal before the 5K, but wonder what you say. Okay. So when it comes to walking or running or activities where you're in a sport, you're going to be sweating a little bit more. You do need to kind of have a game plan in mind, Theresa. So kudos to you. Here's what I would do, Theresa. It's obviously going to be, outdoors. Practice walking outdoors and see what your leg does. So if you're up to walking, let's say you're walking a mile and a half at this point, Theresa, practice walking outdoors and take your leg off at the half-mile mark just to see what happens to your skin. Are you developing any red spots? Hopefully no blisters, okay? For me personally, I love recommending, and of course I don't have my samples here on me because I've been giving them away, my Vital Fit products. Their liquid to powder lotion, Theresa, is really, really good for helping with the sweat and keeping things good there. The other thing, I'm conflicted with the liners. I'll be honest, guys. I know many people use the liners. It's like a little thin sock that goes on your skin to help kind of wick or absorb the sweat. But here's the deal. Your regular liner, the whole purpose of it is to go directly on your skin, right? It's supposed to be in total contact with your skin. So if you have anything in between your skin and the liner, like a liner, there's a potential there for friction, right? And there's also the potential that you're not going to get as good of a total contact, with your liner. Okay. Now, that being said, do I have people who come in and they say, I love my liner. It helps me when I'm really sweaty. I don't have any problems with my skin. I don't have any problems with my fit. And I go, okay, if it ain't broke, don't fix it. Theresa, with you, I would just try first with the liquid to powder. I think you've ordered some at some point. Try the liquid to powder. Okay. And then if your liner is fitting nice and snug, okay, hopefully that will prevent any friction. Right? And just experiment outdoors, practice walking outdoors, which is the environment that you'll be in for your 5K. So Michelle says, not underneath the skin. So Michelle, I don't know. And that's something that, again, I'd have to be there kind of poking at it. There's a lot of things that can form under the skin. It could be lots of things that can happen there. So if it's something that's underneath your skin that you can feel it, it's causing you pain, it's a good idea just to get it checked out by the doctor. Okay. It could be something as simple as maybe a little cyst that's forming, or it could very well be a neuroma. But again, it's something you should probably get it checked out by the doctor. Somebody needs to lay eyes and hands on it to really be able to tell you what's going on. Michelle says, I feel electricity when I press on it. Okay, so it could be, Michelle, that yes, maybe that is a neuroma, or maybe there's a neuroma underneath that, or a nerve underneath that when you push it, then it's pushing on that nerve. Does that make sense? Susan, always a pleasure to have you on board. Let's see, we've got Tracy says, husband is very active on his 3rd socket in 9 months in surgery. Previous ones fall off after a couple of hours, even after multiple layers. Latest is a RevoFit 2. The knobs keep locking up. Very frustrating for him as he is motivated and only uses the prosthetic for mobility. So Tracy, RevoFit, it's one of those adjustable sockets out there by Click Medical. Great. It's a great adjustable and great dial. If there's something locking up with the dial, Tracy, you need to take that back to the prosthetist, okay? And they need to figure out what's going on, because the whole purpose of those dials is they twist and they turn and they do their job quite nicely. I have a couple people that I know that are using it and they're very happy with it. The other thing to talk about is if they're falling off within a couple of hours of use, even after multiple layers. Tracy, I guess my question would be, has your prosthetist talked about a pin lock system? And actually, I had a very similar question came in this week. This person talking about how their friend's socket keeps slipping off, even though it's a suction socket. So number one, checking the fit of the socket, making sure that socket is fitting properly. And it could be, I believe the RevoFit, don't quote me on this one, guys. I believe the RevoFit goes up to 10 ply in adjustability. Okay. So Tracy, again, take this back to the prosthetist, talk to them about the knobs. They need to figure out what's going on there with the knob. And then also find out, are there other suspension systems that you need to have a conversation about? Is it a matter of adjusting the fit of the socket and maybe that will be all that's needed? Or do you need to start talking about an additional suspension system to help keep that on? Because yes, the leg shouldn't just be falling off after a couple of hours, especially if you're adjusting it with the dials, okay? Mark says, Blatford let him have a long trial on the Elan IC. Yep. So Keith uses the dry sol for sweat management. Okay, let's see what else we got. Okay. I think I made it through all the questions. All right, guys. Just as a quick update, go to my YouTube channel. I'm going to go ahead and post that one again. If you haven't already done so, please consider subscribing to my YouTube channel. It helps with SEO and it helps get the word out there. Also, all the stuff that I talked about tonight, guys, there's some flavor form of video on my YouTube channel that goes into a little bit more detail, okay? Guys, November 3rd, put it on your calendars. Go subscribe for my email list. And next week, general question and answer. So send me those questions, guys, all right? And I'm going to be going through these questions later on this evening to make sure I didn't miss anything. All right, guys, on that note, It's been a long day. Thank you so much again for letting me be a part of your lives this evening. I will see you guys same bat time, same bat channel next week. God bless.